trying to understand the needs and the desires
Yes.
that the person has, trying to communicate to them the reality of how much we can improve that, and to counterbalance or inform people about the potential risk.
The diagnosis of essential tremor for a neurologist like myself is primarily a clinical diagnosis. That means the old, if you consider them old techniques of listening to the story from the patient and examining the patient at the bedside are really the most important ways of differentiating essential tremor from competing causes like Parkinson's disease or other conditions like dystonic tremor.
They're all happy immediately after surgery. This is a chronic condition that people have had for years. We want to see how they're doing a year after surgery or longer than that. So we've had to wait until the first cohort of patients have had long-term follow-up. We've collected that data, and that's being reviewed for publication at the moment.
Thank you very much for joining us this afternoon. So I have Dr. Tabish Saifee with me, and I have Professor Ludvic Zrinzo, and we're going to talk about MR-guided focused ultrasound. So this is a technique that we use to treat patients who have essential tremor, and I just want to understand the patient pathway and the treatment that you do for these people. So Tabish, would you like to start, and how patients are selected? What sort of patients are a part of this?
So we look for patients with essential tremor. Essential tremor is a common condition. It probably affects a few percent of the UK's population, between 1% and 5%. And people usually develop a shake or a tremor in the hands, sometimes in other body parts as well, like the head or the legs, but usually it's in the hands. And usually it's something that affects both hands, and it can develop and worsen very gradually over the years. They find it difficult to hold things, to write, to sort of perform the normal daily activities that they'd be accustomed to. Patients, so people with this sort of tremor, can notice some interesting things, like it may run in the family, doesn't always. It might transiently improve with alcohol. And they tend to seek some advice, often from their GP, or and then are referred to a specialist like me.
How old are patients? Are they're young? Are they old? Or is it?
So it can actually span a lot of ages, and there's a lot of research that's shown that the incidence is something called bimodal. So there's a peak at an early age, sort of around the age of 20, and then a later peak of patients developing symptoms a bit later in life, in sort of mid to late life. So there seems to be two little peaks at which people first start developing symptoms. But as I said, it tends to progress, and it's a long-term condition that doesn't go away.
Okay. So when they've come to you, you're obviously one of the experts in movement disorders in Queen Square. So what tests do you do? Because I'd imagine there's quite a variety of tremor, and has the GP got it right, is what I'm suggesting.
Yeah, that's right, Jodie. I think it can be tricky in primary care to make the diagnosis because it sits with other conditions that cause tremor, for example, Parkinson's disease, and it can be difficult in primary care to differentiate those. The diagnosis of essential tremor for a neurologist like myself is primarily a clinical diagnosis. That means the old, if you consider them old techniques of listening to the story from the patient and examining the patient at the bedside are really the most important ways of differentiating essential tremor from competing causes like Parkinson's disease or other conditions like dystonic tremor. We do often use blood tests, but blood tests are only to rule out much less likely causes, for example, disorders of the thyroid, but often those have already been done in primary care. And occasionally we'll reach out for specialist types of scans. Those might be MRI scans, they may be SPECT scans, etc. So it very much depends on the patient, but a lot of the diagnosis is clinical.
That's refreshing, actually, isn't it?
Yeah,
it's sort of old age, really, isn't it?
Well,
Which is
it's
nice.
the thing that works best.
Yes,
so,
exactly.
Yeah.
I've often heard that with doctors, and I have to say that it does work best. So you have a patient then with essential tremor. What do you then go to? Would we next go to the MDT, the multidisciplinary team for our service? So what happens there?
Well, often it depends on how severe the tremor is and how much the patient feels they need treatment. And there are a number of options. Sometimes we opt for quite conservative approaches and sort of changing and adapting things in somebody's sort of daily life to accommodate the tremor. Sometimes and often we'll try medications. There are a few medications that can help, but there are many patients in whom medications don't work or side effects sort of prevent us achieving a desired good outcome. In a few patients, we do use botulinum toxin, which are injections we can use to hand or arm muscles, which can be effective in a small group of patients. But in the rest, particularly where tremor is disabling and it's affecting people's day-to-day lives and causing their quality of life to be particularly impaired, then these are the sorts of patients who would benefit from what we call functional neurosurgical options, which include focused ultrasound.
Yes. And the decision at the MDT is to collectively, neurosurgeon and neurologist, come together and basically look at the patient and then make a decision about which is the best treatment option. Is that right? And I think you could tell us what the treatment options are, Ludvic.
Sure. So as Tabish was saying, when a patient has reached the point that they're not making the progress they want to make with conventional means, we often meet the patient together. I think it's a really good way of assessing patients. Sometimes diseases change over time and the needs of the patient changes over time. So what's something that's really important from my point of view is to understand how those symptoms are bothering that person and what the objective is and what the desired outcome is for that person. And we go through very much a clinical assessment, as Tabish was saying, with a mind on what the objectives are at that MDT, at that multidisciplinary clinic. And we talked earlier about the fact that we have a number of tools at our disposal now. We have deep brain stimulation, which, if you like, is the most invasive because it requires hardware to be implanted, even though it's a minimally invasive procedure. We have the old way of making a lesion, the radiofrequency ablation, and the newer technology of MR-guided focused ultrasound. And I think what the interaction between neurologists and neurosurgeons, or the close interaction, if you like, has brought on is that neurologists see the power of this tool and they see how effective it can be and how safe it is in modern hands. And that's got a lot to do with the quality of MR imaging improving. Bottom line, if you can see what you're trying to hit, you're more likely to hit it. It's not exactly rocket science. And I think the threshold for wanting to intervene has come down to a degree. Some people who may have been told, oh, you should put up with it because brain surgery is really dangerous. I think now that's shifted, and now we know that actually surgery is really safe. And in well-selected patients can give really good results. So I think initially we were seeing people with very, very severe tremor.
Yes.
Of course, the worse the symptoms, the more difficult it is to achieve a complete abolition of that tremor.
Of course.
But as the years go by, we're now seeing patients with perhaps less severe tremor, nevertheless affecting their quality of life. But the threshold for us offering one of these types of surgeries has come down. And I think there is a perception, certainly from patients, as well as from doctors, that focused ultrasound is less invasive. I like to call it an incisionless technique because we are making a tiny little burn in the brain.
Sure.
But we don't have to make an incision in the scalp or a hole in the bone. And
it's got to be a benefit, hasn't it? Really?
It's really gratifying to be able to do surgery without getting your hands dirty, so to speak.
Absolutely.
So yes, there is that discussion that goes on as to whether surgery is the right thing, which surgical procedure is better for that particular individual, together with an important discussion about the potential side effects. And I think the one that we worry most about, if you like, is problems with balance.
Right. Tell me about why is that? Tell me about.
So the circuits that control or drive tremor are also very, very involved or very close to the circuits that help us with our tremor.
Right.
With our balance. And therefore, we tend to restrict surgery to one side at a time, because if you hit both sides of the brain on the same day, you can have a significant effect on balance. The last thing we want to do is for people to be worse off on one hand, even though they're better off from the tremor point of view. So if you have very bad balance, we may suggest a gentler procedure, or may suggest sometimes not having surgery.
Right.
And we will test your balance very carefully during that assessment. But very often patients' balance is fine, or they have a good, what we call functional reserve.
Mm-hmm.
And we make that assessment that they can tolerate that small hit.
Yes.
And they will improve after the surgery, even if it's affected, because it doesn't always affect your balance negatively. But we always prepare patients for the potential that it might be affected, and we advise them to use a stick for the first few days or week after the procedure. Sure. The reason we say that is that although we assess patients immediately after the procedure, sometimes the balance can get worse before it gets better.
Right, okay.
And the reason for that is when you make a little burn in the brain, whether you're using focused ultrasound or radiofrequency ablation, it's a bit like making a cigarette burn on your hand. Mm-hmm. You'll have the burn itself, but then you'll have a ring of inflamed tissue around it,
right?
Which over the days, the inflammation will settle down. And that degree of inflammation changes between people. So
as it resolves.
Yeah. So I might twist my ankle and have absolutely no swelling the day after, or I might wake up and it's like a football.
Yeah.
And it's difficult to predict that.
Sure.
One of the precautions we take is to give medication that limits the swelling. It's called a steroid.
Yep.
And we prescribe that for a few days after the operation. Mm-hmm. But as I say, it's this sort of thing. It's trying to understand the needs and the desires that the person has, trying to communicate to them the reality of how much we can improve that, and to counterbalance or inform people about the potential risk. And of course, the best patients are those who have the best chance of improvement with the smallest chance of causing harm.
On the day itself of treatment, can you just explain what sort of testing that is done from a neurological point of view? Is it, because I presume you've got to get a baseline. Is that right? Yep.
Yeah, so on the day, patients are brought in, their sort of tremor is assessed, and there's a scoring system for tremor to look at patients doing certain things, for example, writing, but it's also assessing their tremor in certain positions when their hands are at rest,
right,
or when they're outstretched, or when they're sort of moving.
Mm-hmm. And so from there, that's your baseline. And then I understand the patient has to have their head shaped for this procedure.
Yes. So we talked about the fact that we're using energy through ultrasound waves, and it's really important that ultrasound energy is deposited where we want it to be deposited. And the problem with having hair is that the hair traps tiny little air bubbles around the follicles, around the hair follicles, and therefore that can disrupt the energy from getting through. So going back to ultrasound, where most people know it, when you're looking at babies inside their mummy's tummy, we actually use a gel, don't we? Between the probe, you might remember.
I used to do ultrasonography many years ago.
So you've been at both ends of the probe then. And that gel transmits the ultrasound waves more efficiently from your probe that's generating the ultrasound through the gel, through the tummy, onto the baby, and back again as an echo.
Yep.
Now, if you have hair in between, the ultrasound energy just won't get through. Mm-hmm. So at this moment in time, the technology is such that we have to shave the head. Of course, some people don't like that, and you can use a wig until your hair grows back, but the head will eventually grow back. Yeah. And then we attach a frame to the head, and it's very important that the head is kept very, very still during the procedure, because
you're targeting something like minuscule.
Absolutely. If you move, we spent hours targeting this, or I spent some time getting lovely images to make sure we hit the right spot, and then you move, and therefore what we do is hold the head very tightly in place with the frame. This is applied under a local anesthetic, and we have 4 little pins at the front of the head, 2 at the front and 2 at the back that hold the head in place. It's a little bit uncomfortable, but not too uncomfortable at all. And many people tell us it feels like a tight hat when the thing's being applied.
Okay, yeah.
And then just like we use gel in the baby example, we have to use fluid around the head to transmit the ultrasound waves. And also that fluid is cooled down so that it absorbs some of the heat that's deposited in the skull as the ultrasound goes through. So we cool down the top of the head. So we have this contraption that looks like a bit like an angel's halo.
It sounds rather strange, doesn't it?
It does. We've got some very interesting pictures. Patients love to have their portrait to show to their grandkids and whatnot. But we have this silastic elastic diaphragm that goes around the head. And then we position the patient in the scanner. So lying down, we get the most comfortable as we can do. And then we dock what we call the focused ultrasound transducer. It looks a bit like a helmet that goes on top of the head, and it's sealed around this rubber ring.
Fabulous.
So that then we can put cold water between above that rubber ring and between the rubber ring and the focused ultrasound element.
Just takes away the heat, doesn't it? Yeah.
Correct.
Yeah.
The whole thing can go into the MRI scanner.
Yeah.
And that's where the magic happens, where we then use the MRI to visualize the spot in the brain that's misbehaving. And here is where we use our neurologists a lot, because they continue to assess the tremor during the procedure.
So you bring the patient out?
So the patient will always be on the scanner table, but they can come in and out of the scanner as the procedure goes on. But the first thing we do is we image the brain, and we reference that with even more detailed images that we would have gotten before. And then we focus all these ultrasound elements on that spot of the brain that we think is misbehaving. But before we make the lesion, we actually raise the temperature by just a few degrees.
Right.
So we put a small amount of energy through the head. And that causes that area of the brain to heat up a little bit.
Right.
It won't kill it immediately. It won't destroy it or burn it immediately. But that part of the brain will temporarily stop working. So what we hope to see is that the tremor actually gets better because we're in the right spot.
So you bring the patient out at that stage, and then you're doing spirals with them, aren't you? Is that right?
There's a number of tests we do.
Yep.
So Tabish might ask them to do spirals, might ask them to put their hand out.
That way we can assess the tremor and determine how effective this sort of temporary warming up of the area
and you know your target's right then as well. If you've got a really good improvement, then you know the target's right.
Absolutely. And our neurology team will also be assessing for side effects. So, for example, the part of the brain very close to this is the part of the brain that we use for sensation. So if there's any numbness, we know we might not be exactly in the right spot.
Right.
So we let that part of the brain cool down, move our target slightly, and adjust it according to the effects that we see from the patient. Now, we're very, very lucky. As I said before, we've drawn on decades of research that we've had from all the other treatments that we've given, including deep brain stimulation, the radiofrequency ablation. And we can actually see this part of the brain that's misbehaving on these specialized MRI scans that we developed here at Queen Square. So just to give you an example, if you look at the literature of publications in focused ultrasound, the average number of sonications, that's the number of times energy is given before you make the final lesion, is 12.
So the temporary heating up.
Exactly.
Yeah.
So the average is about 12. So people try and get to the spot, and then they find they have to adjust that slightly, etc., etc. Our average is 4 to 5.
Gosh.
And that's because we can see the target so well, we don't need to make many adjustments at all.
That's fantastic.
And that makes our life easier. It makes our neurologist's life easier. But more importantly,
it
makes the patient's life easier.
Because I would imagine that increasing the number of sonifications, doesn't that couldn't be good, could it?
Well, it's just a question of time, really.
Yes.
But the other issue is that every time the ultrasound energy goes through the skull heats up a little bit, despite our trying to keep the temperature down, and the efficiency of transmission of the energy doesn't remain as high as it was in the beginning of the procedure.
Okay.
So the perceived knowledge in the focused ultrasound community is, as long as you can do this safely and effectively, do it as quickly as you can.
Yeah. And so have you been able to publish any outcomes of the work that you've done here in Queen Square? We've
looked at the first cohort of patients who have had long-term follow-up, because the truth is, Jodie, there's no point looking at patients immediately after surgery. They're all happy immediately after surgery. This is a chronic condition that people have had for years. We want to see how they're doing a year after surgery or longer than that. Yeah. So we've had to wait until the first cohort of patients have had long-term follow-up. We've collected that data, and that's being reviewed for publication at the moment.
Oh, that's exciting.
And we're very hopeful that will be
So what any sneak preview of that results?
Well, I think one of the numbers, if you like, that I'm very proud of is this sonication, because as a surgeon, targeting is the be-all and end-all. And I think there's a really good surrogate marker for how good we are at getting the targeting right. Of course, what's important for the patient and for our neurologists who have sent us those patients is the outcome.
Yeah.
And the outcome is just as good as the highest publications out there. We're very pleased with that. The most important clinical outcome, if you like, is that our side effects are much, much lower.
Really?
So if you look at long-term problems with balance, for example,
yes.
Ours is a fraction of the published experience
to
date. If you look at numbness, we have no patients who have numbness.
Does that go back because of the reduced number of sonification? Do you think there's a correlation there between if other sites doing, say, maybe 12 and you're doing 4?
I think it's
related?
I think it's multifactorial. I think number one, we have a really good team in terms of selecting the right patients. I think number two, we're building on the experience that we've used for imaging and targeting from deep brain stimulation and radiofrequency ablation, where we are global leaders, if you like, in terms of developing those imaging sequences. But we're also building on the shoulders of giants who've used focused ultrasound before us.
Yes.
So before starting up the service some years ago, we went to visit high volume centers that were lucky enough to have focused ultrasound in the beginning in the States and abroad. And, they told us what worked and what didn't.
Yes.
So we used their learning curve, if you like.
Fantastic. And manuals
on top of the expertise that we have.
And Tabish, with regards to this technique, do you think there's other opportunities to use it for other diseases or other applications? What's your views?
It's a technique that's not been first used in tremor. It's been used in other arenas, for example, in the treatment of prostate cancer, just as an example. There are certainly other areas within neurology, neuroscience, and neurosurgery that it will be used for. I know, Ludvic, you're particularly interested in a couple of novel potential uses, so we'll definitely see its use expanding, I think, which is very interesting. It's a great technique. It's less invasive than other forms that we've already discussed. But I think it's the areas it's used in will widen. And Ludvic, you may want to mention about some of your interest in there.
So I think we can look at this as different indications. What different types of diseases can we treat? We can look at this as different areas or different targets within the brain that we can use to treat. If we start with, for example, Parkinson's disease, although we know that we can help patients with Parkinson's disease tremor by targeting the very same area of the brain that we use for patients with essential tremor, Parkinson's disease often comes with other symptoms like slowness and rigidity and stiffness. And different parts of the brain have been targeted using deep brain stimulation. And there's a very good pioneering group in Spain who are looking at using focused ultrasound to make a lesion of this area of the brain called the subthalamic nucleus.
Right, okay. Yep.
And that's something that we'd really like to do further research on. It's not something that's widely accepted at the moment, but the early data looks really interesting. And if we ever have the opportunity to perform a clinical trial for this, and in particular, patients who are a bit younger, if you like, have early onset Parkinson's disease, but have very asymmetric disease. That means that one side of the body is much more severely affected than the other. They encounter huge difficulties in the sense that our neurology colleagues give them medication to help with their affected side. But when you give them enough medication to help with the affected side, you can get dyskinesia or abnormal movement, excessive movements on the less affected side. So patients often feel a bit unbalanced, either because they're undertreated for the severely affected side or they're overtreated for the affected side. And what seems to be coming out from this early research is that these particular patients who have focused ultrasound of this different part of the brain, even 3 years after the procedure, are still having significant benefits from the procedure. So this is a way of helping this severely affected and fairly young group of patients. What I'd like to see is if we get involved with this sort of research, you learn a lot from those people. And in future, we may be able to target other people with Parkinson's disease symptoms.
So the sort of things you've just been talking about, others may have been doing it around the world. Is there something that as Queen Square consultants, you want to be the first to be doing? What's the burning desire for both of you in this field? Well,
the burning desire for me is to get our centre recognised by the NHS commissioners, because at the moment there are only 2 centres in England that are commissioned for this. And although we can very well treat private patients, we can't treat NHS patients yet. But we're hoping that we can convince commissioners that this is the right use of this machine, that there are patients who are waiting for several years to have this treatment in other centres because there's a huge backlog of patients. And it seems a shame to have the equipment, have the team, a team who's actually pretty good at doing this, and not using it. So that's our first goal. And then once we are working within the auspices of the NHS, we're really keen to apply for research funding to do studies such as looking at focused ultrasound for Parkinson's disease, looking at second side surgery for patients with essential tremor, and then potentially even looking for focused ultrasound, whether we can help or better help people with mental health conditions like OCD or depression. And you know, it's a journey.
Yes.
Everything takes time. Whenever money is involved, of course, that always raises eyebrows. But I firmly believe that these are chronic conditions that affect a significant portion of the population. And people are the best asset that a country has.
Absolutely.
And if we can get these people less dependent on carers, if we can help these people remain in work for longer by treating them earlier on, I think that we have to look more globally at what these treatments can do for our nation, rather than just looking at the health costs and saying we can't afford that.
Yes.
It's a bit like education. The only thing more expensive than a good education is no education.
Yes, exactly.
And the only thing more expensive than reduced access or good access to healthcare is reduced access to healthcare.
Absolutely. And you concur that, I would imagine, Tabish?
Yeah, absolutely. I mean, it's, such a life-changing treatment for many patients. Lots of people have had their sort of lives turned around after this sort of treatment. They can get people back to work, doing the things that they used to do before their tremor was so severe, and it's really wonderful to see that.
Yes, yeah.
I really hope that we are able to offer that on a wider scale through the NHS.
I always remember one of the patients that we treated, and he sent me an email afterwards, and he said, "I'm so much less angry." Because he was just so frustrated what his tremor was stopping him doing. And he said, "You have no idea. You not only enabled me to have a better life, but I'm so less angry. And my family, I've got the old me back." And it was almost very, I wanted to cry when I was reading it. But,
that's right. It's incredibly frustrating because it not only affects work, it affects people's hobbies, whether that's sports, instruments.
And their relationship with their family, because, he was the grumpy old man. No one wanted to have him at the family dinner because he was just, so frustrated. So keep on doing all the good things we're doing.
Socially very impairing, and people become very aware of their tremor and prefer not to go out, not to socialise and mingle with family and friends. And that's a very disabling aspect of the condition,
That's fabulous. Well, thank you both very much for having a chat with me today.
Thanks for the opportunity.
Thank you very much, Jodie.